Hello, everyone, and thank you for joining the POCUS Certification Academy for today's POCUS Bites webinar. My name is Alex, and I will be your webinar host for today. The webinar is now beginning, so all lines have been muted. If you have questions, please direct them to the Q&A box for a Q&A session after the presentation. You are also welcome to use the chat box for any comments, insights you'd like to share with the group and the presenter today. Today's topic is Introduction to Nerve Blocks in Primary Care, and our speaker is Dr. Bruno Vargas Garcia. Bruno, originally from Mexico City, attended medical school at the Universidad Nacional Autónoma de México, or UNAM, in Mexico City. He completed his social service year in the Sierra Madre of Chiapas with Partners in Health Mexico, or Compañeros en Salud, CES for short, in 2019. During this time, he trained in global health, social medicine, and was introduced to the point-of-care ultrasound, POCUS. He became passionate about POCUS during this time while working in a resource-limited setting. Later, he stayed with CES during the pandemic as part of the COVID-19 task force, where he worked with community healthcare workers and pasantes, or first-year doctors doing their year of social service. Later, he finished the Ultrasound Leadership Academy, ULA, fellowship and started a POCUS training program at his site with the midwives, nurses, doctors, and trainees from these areas. Currently, Bruno is doing a global health fellowship with HEAL as a site fellow in Chiapas with CES and has committed to a lifelong career in global health, providing healthcare access to the most marginalized communities. He is passionate about nerve blocks and interested in making POCUS available in resource-limited settings through task-sharing strategies. Bruno has a profound respect and admiration for nature and loves any kind of outdoor activities, especially bicycling, high mountain climbing, and scuba diving. Please welcome our speaker today, Dr. Bruno Vargas.
Hello, thank you, Alex. Hello, everyone. Welcome. So nice to have so many people around. So I'm going to start sharing my screen. And so here we go. So today I'm going to talk from the site where I work, which is Compañeros en Salud, or CES. I'm Bruno Vargas, and today we're going to talk about a brief introduction of nerve blocks in primary care. So just to review the objectives of the lecture, which is going to be understand the benefits and risk of nerve blocks, know the correct technique for nerve blocks, and we're just going to review a little bit about medial, ulnar, axilar, popliteal or sciatic nerve block, and tibial posterior. But before going that, I think it's important for you to know a little bit about where we work and what we do and why I became so passionate about nerve blocks. So this is the community where I did my social year service. This is Letrero. And when the lights go out almost once per week, you can see the Milky Way. It's a small community on top of the mountains. There's nothing around. There's no big cities. You can only go in and go out through dirt roads for 4 hours. And that primary care clinic is basically the only healthcare service that it's in kilometers from that town. It looks a lot like this. So this is Jaltenango de la Paz. This is the closest, biggest city that has a basic community hospital. And these are all the clinics where CES works. And I was here in Letrero, which is called the District 13, because we are the furthest from everyone. And we're just a tribute. And if you want to go from Letrero to Tuxtla Gutierrez, which is the closest hospital that has like any kind of specialty service, it will take you 5 hours driving. And the terrain is like this, it's Sierra. It's just full of mountains. And when you move around from one place to another, you have to go through hours of dirt roads, bumpy roads through the Sierra. Great view, but terrible if you have a broken hip or a broken femur or a broken anything, or you are in extreme pain and you have to be just moving around for a couple of hours. There's no airlift, and the only way to go in and go out is through the roads. And disclaimer for the next images, but this is something that happens pretty often in the region because we're coffee. This is a region where there's like a lot of coffee plantations, so there happens a lot of accidents all the time. And sometimes it's really hard for patients to get access to care, and they have to do a lot of out-of-pocket expenses, or even if they go to the hospitals and the public services, they will be denied the service. And you get also a lot of fractures all the time. So imagine just going for 5 hours with your broken ankle just on a bumpy road. It's not something nice. So nerve blocks are amazing. They're incredible. And it's not only that I say it, but there's a lot of literature that say about how cool nerve blocks are and how much they benefit patients and how they can do a lot for patients. So this is just a brief articles from the literature of nerve blocks. I just chose these four. So for example, this was on the top left, there's this article. It was ultrasound guidance, and they compared the use of ultrasound guided procedures versus nerve stimulation and for supraclavicular block. And what they found is like with the ultrasound group, there was no need for general anesthesia. Like most of the time they work. With the nerve stimulation group, 8% of the times they needed to go to general anesthesia because the block just wasn't good enough. Also, the quality of the block was better. Sometimes with the supraclavicular, you don't get such a good the ulnar nerve. It doesn't block so much, but when you do ultrasound, it gets better. It works just better. The time of the procedure is shorter. Ultrasound 5 minutes, nerve stimulation 9.8 minutes. Also, this one about pediatric literature, where they have the impact of ultrasound guided femoral nerve blocks in patients that have a hip pain related to fracture. And what they found out is that when you're doing ultrasound ultrasound and compared with general anesthesia, what you have is like the ultrasound has a longer duration that anesthesia that you have to apply constantly. You need fewer doses of analgesics, and also you require your nurse team to be doing less interventions and having more time for doing other stuff because they have to be applying more doses and keeping an eye on the patient, especially if you're applying systemic analgesics. And there's a lot of things. For example, this is the 3-in-1 block for hip fracture. Well, it's for the hip basically. And what they saw between the ultrasound and their nerve stimulation group is like the time of onset, the time for the analgesic to start was less in the ultrasound group. And also the quality of the nerve block. They use a scale where 100% is you have full sensibility of your arm, your leg, and 0% is you don't feel anything. And after 60 minutes, they saw that only 50% reported some degree. They reported 15% of sensibility. So 100% is you can feel everything, 0% is you can't feel anything. And in the nerve stimulation group, it was 27. So actually, it works better. It's more quality. It takes less time. It has a faster answer time. It has longer duration. And also in this test, they saw in this study, they saw that it decreased the risk of vasculature puncture. So in conclusion, nerve blocks are amazing. They are most likely to be successful than other methods you can use. They take less time to perform. They start faster. They have a longer duration. You have decreased risk of complication. The quality of the blocks are better, and you need a lower dose of analgesics. However, nerve blocks are not perfect. There are complications, and the four most important complications are peripheral nerve injury, that can be permanent or just transient. Block failure, just means the block doesn't work. You can have bleeding, hematoma, or you can have local anesthetic systemic toxicity. And we're going to talk about the two most important, or the things that I consider most important, because we don't have a lot of time, but it's the peripheral nerve block and the local anesthetic systemic toxicity. So the peripheral nerve block happens basically because here is your nerve and there's all the bundles, and it's covered in a fascia plane. And what happens or what they think it happens, because we are not entirely sure, is that it's more common when you put your knee through the nerve and you inject your anesthetic, and that may cause a permanent damage or transient damage. What you actually want to do with nerve blocks is that you don't want to put your needle or your anesthetic directly into the nerve. You want to do it in the facial plane where the nerve runs. And then you put your anesthetic and you put it around it, you surround it. That's what you want to do. So peripheral nerve injury are rare. There's not much data and it's not reliable. Some people say that it occurs less than 0.1% of procedures. Others say it's 1.5 for every 10,000 procedures. It's rare, but it happens. And something that can tell you a worrisome sign is like if during the procedure the patient has pain or paresthesia, it may have been that you went a little bit too far and touched that nerve, or you put too much pressure and volume and it's actually just squeezing the nerve, which is also important to know about the volume that you're applying. And the local anesthetic systemic toxicity, or LAST, had happened because you inject anesthetic into a vessel, or there was a vascular uptake from having just a big volume or high doses with high concentration around the vascular, and it just goes through it. It happens more with lipophilic anesthetic. Bupivacaine is more lipophilic, so it's more common to have LAST with bupivacaine, although it's still not so common. They say it's 25 per every 10,000 nerve blocks. So it's not that common. But when you have a LAST, you're not gonna be happy in your patient either, because it starts normally with signs and symptoms with the central nervous system. You have the patient starts to feel tinnitus, has a metallic taste, has perioral numbness, it may feel agitated, a little bit of confusion, drowsiness, it may have auditory changes, just like tinnitus, and it may end up to seizures. And then it can go into a cardiac toxicity later, which will give you hypotension, bradycardia, tachycardia, arrhythmias, and cardiac arrest. Sometimes it can go directly into cardiac toxicity and not go through the central nervous system or have both things at the same time. So normally what you do is you have to stop the medication, you have to give life support, and you have to apply a lipid therapy and ask for help. That's what you have to do. But it's important for you to know these things. And there are a lot of resources out there. And if you're going to start doing nerve blocks, you have to get yourself into know about these complications. So let's go with the scanning technique. So before you do your scanning technique, there's three things that you want to know. You want to know what are you going to use, how are you going to use it, and why you're going to use it, or why you're going to do your nerve block. So from the what transducer we need? Do we need cover? We need to clean it? What kind of needle do I need? And most importantly, what kind of anesthetic am I going to use, and what's going to be the dose and the volume? Because volume and dose and concentration, it's super important when you're doing nerve blocks. So for transducer, you're gonna go with your linear probe. Has to be a high frequency for the nerve blocks that we're gonna review, which are like the introductory nerve blocks. These are the ones which I started because they're easy and you are far from the pleura or big vessels. So it's less probable that you will get in trouble. And I recommend you starting with these ones before going into the big nerve blocks. So just a high frequency transducer from 12 to 4 megahertz. What you need is you need to put some kind of cover to that probe. Probes are super dirty. There's a lot of literature about what they can find in there, a lot of bacteria, things. So use a cover. We use one of these Tegaderms, and they're incredible. You just have to use sterile gloves and make sure that it just like covers completely the surface of contact of the probe. And for cleaning, you can use povidone or chlorhexidine. And always remember that you're going to use single-use sterile gel. You're not going to use those reusable gels or non-sterile. You're going to do a procedure, so you want to keep it clean. It's clean. You want to wash your hands, use a mask, basic things. And then we go for the needle. So this is a normal needle, and this is a spinal needle. So you normally are going to need longer needles for nerve blocks, and that depends a lot on the patient. If it's a little bit fluffy, it has a lot of musculature. If it's not if it's thin, it might work if you use a normal syringe. But normally you're going to use the 100 to 120 millimeter syringe. Look out for the needle tip. Some have a non-cutting; those are the best. And there's some that are like actually especially for nerve blocks, and they are more echogenic, and it's easy to see them and follow them when you're doing the procedure. But I don't have it on our site because it's a resource limit setting. But we use spinal needles, and they're great. They work incredible. But if you have the resources, get them. So, anesthetics. So, these are the three basic, and I think the three that are most used. So, you have lidocaine, which is a short-acting anesthetic. It will last for 1 or 2 hours. You have bupivacaine, and then you have ropivacaine. You need to know what's the maximal dose of the anesthetic that you're going to use. You want to know what's the onset time in minutes, because that way you will know if it's actually acting or not, or if you how much you have to wait before you have to do your procedure, and what's the duration. And that's super important, because if you're going to take a bumpy road with a broken hip for 5 hours, I hope you will not use lidocaine, and then you will use ropivacaine or bupivacaine. So it's important for you to know this, and also knowing the concentration, because you're going to know what's the volume that you're going to inject. And that depends a lot in the kind of nerve blocks that you're going to do. So you want to know concentration, volume, dose, time, and also know this cool fact about steroids. So when calculating your nerve block, your dosing for anesthetic, use a calculator. There are a lot of apps there for nerve blocks you can find, and they have like automatic calculators where you can put the concentration, the weight of the patient, and it will give you the maximal dose that you can apply and the maximal volume. They're incredible. And this is important because when you give a higher concentration or high volume of anesthetic, it's more probable that it will cause a loss syndrome if you go above the dose, because it's more easy that it will be absorbed by the surrounding vasculature. And it's important because for certain nerve blocks, you will need high volume of anesthetic, because you're going in the facial plane. So you might need 5 cc's for a posterior tibial, but you might need 20 for an axilar. Or if you're going to do a 3-in-1, you're going to need even more, 20 cc's. So you have to know the concentration so you can calculate how much volume you're going to put. For example, here for the ulnar medial posterior, 5 cc's. For the axilar and popliteal sciatic, you're going to use 15 to 20 cc's. So you have to know the concentration and the volume. You can use adrenaline to increase the volume. So, epinephrine, lidocaine with epinephrine, it allows you to use more volume. So that's actually easier when you want to go to the 20 cc's. And also, if you combine it with steroids, with dexamethasone, there are some studies that it will actually prolong the duration of the anesthetic for almost double. So that's also good to know. I don't know if there's anything about lidocaine, but for the long-acting anesthetic, there is literature about that. Then you want to know the how. And for the how, you want to know 3 things. You want to be safe for the patient, for you. You want to be comfortable, because if not, you're not gonna enjoy it, and it's gonna be super hard for you. And you want to do it in plane. You're starting. When you have more badges on, you can do off plane. But now that you're starting, if you're entering the world of nerve blocks, go always with in plane. It's easier and it's safer, because you always want to see the whole needle. So for safety, these are really peripheral nerve blocks. They're below the knee and below the elbow. So it's less common that you will have complications. It's more common when you have more proximal nerve blocks. But basic things that you have to do is you just want to monitor vitals. You want to check blood oxygenation. You want to check heart rate. You want to check blood pressure before, during, and after. And this is what you're doing your nerve block. And can be in a primary care. You just put on the monitor, you put the patient, you do the procedure, and always keep the patient safe. Because if there's signs or symptoms of blast, you will see bradycardia, you will see hypotension, and you want to be ready for anything that could happen. Then You want to be comfortable. You want to have the screen of the ultrasound just in front of you, so you can just lift your eyes a little bit and you can just see the screen, and you don't have to turn around, because that's going to make it so hard for you to coordinate. So if you're going to turn around and do 30, it's not going to be possible. You're not going to be able to perform a good nerve block, and it's going to be harder for you, and you might get demotivated. So a lot of the setting is super important. Where are you going to set your machine in relation to the patient? When you can basically just see the screen, just looking up a little bit and look where your needle is going, it's going to be super easy. With screens, you will see it. The thing that we're talking about in plane, this means that your needle is going directly above the long axis, and it's in plane with your transducer, and it looks something like this, where you can see the whole needle, and you can see the point of the needle entering. Here's the nerve. So this is what we call in plane. And here's another video where you're going in plane. And you're going to see also the same. You're going to see your needle going in. Now, why? Why am I doing a nerve block? What are the indications and contraindication? Is it going to benefit the patient? I think it's important to first review the contraindications, the basic ones, like any procedure. If it's allergic to local anesthetics, don't do it. If it has an active infection in the injection site, don't do it. If it has coagulopathies and antibiotic drugs and there's a huge risk of bleeding, don't do it. Maybe you should change to something that requires more control of the situation. If it has a risk of a compartment syndrome, maybe don't do it, because you're going to increase the volume. You're going to go through the facial planes. Then that's perfect. And you might require to contact anesthesiology, or you might require to do a general anesthetic. And the indications, there are a lot of it. Basically, anything that it's any lesion that happens in those regions, it's going to work for you. When you're going to do the medial or ulnar nerve blocks, it can work if you have a boxer fracture. That happens a lot, and you can do, or if you want to do a reduction of the fracture, or put a cast, or if there's some lesion and you want the patient to have more pain, or you have an abscess or any kind of injury, you can do a nerve block, and your patient will feel no pain. And if one day you get a lesion in your hand and you get a nerve block, you will see how amazing they are, because they really are incredible. So how we do it? For the ulnar nerve, it's a little bit more medial. So what I do is I start closer to the wrist, and then I slide superiorly. What I try to do is I try to find my ulnar artery, and the ulnar nerve is going to be next to it. And that's closer to the wrist. When you slide up, they will start to separate. Here's the video. Here is the artery. Here next is the nerve. And you slide up, you slide up, you slide up, and they will start to split. Artery, nerve, look at it, it has this. And boom, they split. And this is where I will do the nerve block, because I'm sure and I'm safe, and I know that the artery is all the way over here, and right here there's nothing, and I know that I'm not gonna puncture any vessel, or if I put a lot of volume, it'll be harder for it to get into the vasculature. So here's your nerve, here's your vessel. So I'm just gonna put the video again. So if you slide from the wrist to the elbow, they will start to separate, and around the middle of the forearm, they will separate into the nerve and the vessel, just like here. And then you will do an in-plane, which means that you will put your syringe. I, in this case, go from middle to lateral, and it will be easier. You will not have any structure that will get in your way. Here's a clip. So here we have the nerve, and here we have the artery, and here is the needle. And what you want to do is you want to put your anesthetic around the nerve block. You want to go into that fascial plane and just do a little bit. You can do a little bit of dissection from the beginning and just give a little bit of anesthetic before getting close to your nerve, so you can dissect the nerve. And what you want to do is you want to put the anesthetic around the nerve block. Here's the point of my needle, right there, and here's the nerve. And depending on the kind of nerve that you're going to do, it's the amount of volume that you're going to use and the concentration of the medication. For the middle, it's the easiest one. Ulnar, sometimes it's harder if you don't see the vessel. With the medium nerve, you just have to put your probe in the middle of the wrist, and then you have to do the same thing. Slide up to the elbow, and you will see your nerve in the middle. And what can help you is also the radial artery, which will be a little bit more lateral. So here is your vessel, and here's your nerve. Look at it. Look at that structure. Looks like a honeycomb, and they are completely separated. And here I would feel really comfortable to do a nerve block far from all the other structures. Here and here. And there you will put your needle up here in an in-plane approach. Then the sciatic popliteal nerve block. This is amazing if you have a fracture of the distal tibia, fibular foot, if you have an Achilles tendon rupture, or if you have any distal lacerations, nasal lacerations, this is going to help you. So it covers these regions. So it doesn't cover that much of the medial face of the lower extremity, but it does cover all these. So you have a lesion over here, the sciatic popliteal is not going to work for you. But if you have fracture from the lateral, it's going to be amazing. So what you're going to do is, first, what you're going to find, or you want to try to find, is your popliteal artery and vein, and you will find two nerves, the tibial nerve that is just above it, and the common peroneal nerve that's a little bit more lateral. And you slide up from where you see your popliteal artery and vein. Here is my popliteal artery, here's the tibial nerve, and here's the common peroneal nerve. And I slide up and see how they get together. Oh, that animation wasn't supposed to be there, and boom, they join together when you slide up. So one more time, you start just at your popliteal artery and vein, and you will have above one nerve and then the other, and you slide up, you follow it, and then we'll get together. And when they are together, that's where you want to put your nerve block, right there. And it will work, and it will cover both nerves. You also, in this case, I will do a lateral to medial approach. That's what works, and it has to do an in-plane. It's easier. Once you get your hands on, maybe you can do it out of plane, but for this lecture, we're just going to go with in-plane. And then the other one is the tibial posterior. It's amazing for virgin bodies, for calcaneus fractures, or lacerations of the plantar foot. It basically covers everything that is in blue, yellow, and green. The areas in red doesn't cover it. It's not covered by the tibial posterior, but it works amazing. And what you do is you want to pay your patient to be comfortable, and you're going to go in the middle side, middle aspect of the foot, and you're going to go in plane, and you're going to go from posterior to anterior. And here, what you're going to see is your artery and your nerve and your calcaneus and your bone, and then they will stay together. They will not separate. So you have to be really careful. It's just next to it. So here's your vessel, and right next to it is your nerve. And then the axillary, which is from these that we have reviewed, this is the hardest. It's incredible for upper extremity fractures. If you have any nasty lacerations in the forearm, in the hand, if like the ones that we saw in the image, this will help you a lot. What's important to know is that actually you're kind of doing a double nerve block, because you're going to be covering all these. You're not going to cover the proximal medial aspect of the upper extremity, but all the other rest up to the point of the fingers and the forearm, it's going to be covered if you do this double nerve block, because you're going to go through the axillary nerve block, where you're going to go to the musculocutaneous nerve. So you're going to do two nerve blocks. You're going to put your needle in one direction, you're going to put anesthetic next to this one in the fascial plane, and then you're going to go close to the axillary artery, and here you will have the three nerves. You want to cover, you can go here, put a little bit, then go on top, put some around here, and you can go down and try to put some below. and you want to cover the 3 nerves. So it's a little bit more complicated. Here, a long needle helps a lot. And the approach that you do is here. The patient just have to be on this position, just like a cactus, or hey, don't shoot me, and then you put your probe there. And it's super easy. It's really easy to find it. And here is on the artery, and here is your 3 nerves surrounding the vessel. And here's a clip from one that I did. And you always, and this is super important, you always want to be looking at your needle. That's the most important thing. If you're not seeing the tip of your needle, don't move any further, don't inject, because you don't know where it is, and you might be over the vessel, or you might be just inside the nerve. So be careful. So here, this is how a needle looks like. Here we're going above, and we're injecting the anesthetic above the axilar artery. Okay. And now pitfalls. There's something, oh, wow. Okay. Sorry, we're having some technical problems. So, we were here. So there are some pitfalls that you want to be aware of. The first is that nerve blocks suffer from the effect of aliasing. So if the sound waves are not completely perpendicular to your nerve, it's going to look a little bit hypoechoic, and it's going to be harder to distinguish. Here's an example. Here I'm tilting the probe, and see how there it almost disappears. There it is. It's completely perpendicular, and then it's gone. Looks a little bit like this. So here is my medial nerve. Look how when I tilt too much and I'm off, I'm not perpendicular, it disappears. And then when I'm perpendicular, it shows up again. So this is something that you want to be aware of, because knowing this will help you find nerve blocks when you're not finding them. Remember, you have to be perpendicular. If you're not, you're gonna be having a hard time finding those nerves. Then the other thing is, be alert. Check the dose and concentration of your anesthetic. You don't want to be the guy that confuse lidocaine 2% by lidocaine 1% and cause some complications. They are rare, but they can happen. Last is related to the concentration and the volume and dose you're giving. So if you're going above the normal dose, you might have local anesthetic systemic toxicity. So be careful, always double check. And remember, there are a lot of apps from nerve blocking that have integrated calculators for all the different local anesthetics that you might be using. And for troubleshooting, remember 3 basic things. You want to be in your position, you want to be comfortable. So have the screen and the patient in a way that you can only just lift your head a little bit and you can see the screen, and then you can do the nerve block. If you're going to be turning around and moving, you're going to miss it and you might harm the patient. So don't do it. Remember, you want to be comfortable. And the patient will be grateful for that, and also your back and your neck. And the other thing is, you can always use color mode, especially to make sure that there's no vessel around the nerve. Here, you're looking at the ulnar nerve. Here's the artery, here's the nerve, and look, here they split. So use a color mode. That will help you see where the vessel really is and make sure that there's nothing around. And here we have the medial nerve right here. And the artery is all the way here. So you're sure that when you're going to be doing your nerve block and you're going to be putting that needle into the patient, you're safe from having any troubles, and the patient wouldn't have any complications. And the other thing is, look around before you block. Do a scan scout. Before trying to put your needle in, go on review. Make sure that there's nothing around. Make sure that there's nothing that you haven't seen, especially with the axillary nerve block. It's a little bit harder sometimes to find a musculocutaneous. The axillary, it's complicated. There are a lot of vessels, but you always can go on top and below. but always look around. Be sure that there's nothing in your way and use color mode. And be confident and practice. If you start practicing with a pork belly or with tofu or with a homemade phantom with jelly, do it. That's going to help you. The most important thing about nerve blocks is that you develop that motor capacity of knowing where your needle is going and keeping your probe in plane. That's the hardest. The sound wave is just too small and the needles are small, so just practice. And this was all. This was the presentation of Introduction to Nerve Blocks. And gracias, and thanks to everyone that came. I'm going to stop sharing. And just one thing, if you're in primary care, you're going to love it. Really, it's going to change it. It's going to make it so much easier for you. You're going to save the patient a lot of time, a lot of money, a lot of nasty travels. So just practice before doing it. It's easy, and it will change the way you do clinical.
Awesome. Well, thank you, Bruno, for that wonderful presentation and for giving all that information. For the audience, Bruno has prepared some questions for everyone. So we're going to go ahead and transition to those questions.
So I'm looking that, yes.
Are you able to see it, Bruno?
Yeah.
Okay, awesome. So we'll give folks a couple minutes to kind of answer. All right. So the big question was, what are some contradictions for nerve blocks? And Bruno, you mentioned these big three ones. Do you want to touch on them just again real quick?
Yes, if there's and I mean the first one is the basic one. If they're allergic to one of the local anesthetics, you don't want to put that one because that's gonna end up terrible. You want to make sure that there's not an active infection in the place where you're gonna do the nerve block, like where you're gonna inject, because that's just not that's basic contradiction of any of those procedures that you're gonna do. If the patient is under anticoagulants and has risk of having a low volume and going into shock and it can bleed, be careful, it's going to bleed, and maybe you don't want to do it. Maybe that's in the case where you want to go for a general anesthetic. And the other one was, I mean, if it has a compartment syndrome, you're going to put a lot more volume and pressure in there, so you don't want to do it. And yeah, those are the basic ones.
Alrighty. Awesome. And launching question number 2 for everyone. So where should you set your ultrasound monitor? All right. Let's see how we all did. Okay. So where should you set your ultrasound monitor? Bruno, you talked a lot about this, making sure you're comfortable, right? That the ultrasound screen is visible to you without having to turn or twist. Do you have any other suggestions for comfortability, both for you and the patient?
Yeah, I think I mean, it's not only about where it is, but if you need to sit down, sit down. If you need to ask for help for someone to help you with holding the probe or with the aspiration of the needle, that will help a lot. It's not bad to ask for help, and especially when you're starting. Once you get a hand to it, maybe you can start doing it alone. But at the beginning, it's good to ask help. It's always good to ask help when you're in trouble. So also always look for your back. You don't want to be completely curved and doing a procedure like this, otherwise you're gonna be having a terrible back day by the end of the day. And yeah. For example, for the ulnar, sometimes you can ask the patient to be on this position, and that will help a lot because it will be more accessible for you. Sometimes when you're doing the ulnar, it's actually harder because you have to tell them to really rotate a lot, and that could be really comfortable for them. So maybe you can ask them to flex, bend their forearm, and you can do the nerve block here. Yeah, for the sciatic, I will put them face down, and that make it so much easier.
Those are some good additional tips, I feel like, getting in those in there. All right. So we'll go ahead and go to the third question that Bruno has prepared for everyone. So where should you inject the anesthesia?
Oh, I'm just gonna add Rashi Al put what is the angle of entry to the block. So that's a good question. So for example, let's say this is your leg and the patient is upside down, you know. Your probe is gonna be on this direction doing a transverse. Your needle, you're gonna want it to go in plane in this direction. And you can go from lateral to medial. That helps a lot. That's how I do it normally. It's easier for me.
Good question. All right. Looks like we got most folks answer question 3, so we'll go ahead and end and then share the results. So it looks like most folks got it. Where should you inject the anesthesia? Into the fascia plane where the nerve runs within. Do you have any additional comments about the injection, Bruno?
Now, just keep in mind the volume. And also, there are a lot of resources out there. There are a lot of cool apps that are free and you can download them. And they will also tell you the volume that you need. There are incredible groups that NISAR has a lot of resources. Highland has a lot of resources. University of Washington has a really cool app about nerve blocks. So use them. They're free and they're good. So yeah.
So, all right. So we're going to launch a poll for the group. This is just kind of helping us receive feedback on webinars. So I'll launch it and leave it open. And while it's open, we'll transition to the Q&A session. So folks will have a chance to kind of answer those questions as well as ask questions directly for Bruno. As a reminder for the Q&A session, if you do have questions, please put them in the Q&A box so that way we can go through them together. All right. It looks like you answered the what is the angle of entry to block a nerve for the sciatic. Okay. So we have a question here. Do you prefer or do you perform proximal sciatic blocks, and in which cases do you perform those?
Yes, I mean, I have to be honest, it's not one that I've done too much because I don't have the need to. And for example, if you haven't like any kind of problem in the whole extremity, I will go with the 3-in-1 plane, which is incredible because you will just block the whole leg. But yeah, I know that you can do a lot of nerve blocks and even from like completely from the gluteus, and they have different indications. I think maybe that's a more advanced, and you might actually need to use a curvilinear probe because there's going to be a lot of tissue between you and the nerve. But for example, for anything that you have like any big problem in the leg, I will go with the 3-in-1 plane, which is also really safe. You just need a lot of volume. But I will say that's a second level nerve block.
Gotcha. So the next webinar you do, we'll include that one. All right, it looks like you might have been in the process of answering this one, but what is lipid emulsion therapy and who starts it?
Okay, yes. So when you have a patient that has LAST, when it has local anesthetic systemic toxicity, like that's the drug or antidote for the anesthetic. So all like most local anesthetic are highly lipophilic. So with the lipid emulsion, able absorb and catch that anesthetic, and it will decrease all these drugs that are into the vasculature, causing all the systemic toxicity. So that's how you want to use it. I have known from personal experience here in my context that it's really hard to get, and I have actually only got it from people that that made me the favor to bring it from another country. So it was hard to get it, and but it's yeah. I mean, I think that if you're gonna be doing nerve blocks, you need to have lipid emission at hand, because if you're gonna have local anesthetic, that's what you want to give the patient. So yeah, try to find it for more, like for example, if you're doing medial or ulnar nerve block, like you're far from a lot of vasculatures, you can do it. I mean, it's safe. Um, Even for the anterior tibial, posterior tibial, like a lot of people that I know, older doctors, use the like anatomic approach, like without ultrasound, and they will puncture the vessel. A lot of the time it's like, oh yeah, that happens. Like, wow. So that's why now we have ultrasound. But yeah, I would recommend you to have lipid immersion therapy if you're gonna go and jump into the bigger nerve blocks.
Alrighty. It looks like we had another one came in. Can you enlighten about hydrodissection of nerves?
Yes, so this is also pretty cool, but sometimes before putting the anesthetic, you can put some water or solution to dissect, and not, sometimes you just have um, a limited amount of volume or concentration from the anesthetic that you have. So what you can do, if you have an extension, you can first put the syringe that has some liquid, and you can dissect and go your way dissecting, and it will also help you see the needle when you're injecting liquid. It will dissect and will make it easier. And once you're in the fascial plane and you're sure and you have put some liquid, then you can change your needle to the one that has the anesthetic, and then you can start putting, and that will help you with volume, and that will help you with not wasting valuable cc's of your local anesthetic.
Awesome. Thank you for that. And then do you do paracervical block for short gynecological procedures for IUD insertion, etc.? What's the tip?
I mean, I for paracervical, for IUD insertion, I do the basic one. I just hold the cervix and I do an injection like the normal, not ultrasound guided. Like, I don't know if there's an ultrasound guided procedure for that, but for that one, I normally go just directly because it's easier. I think it's harder. You're gonna miss and hit something. It's safe, and yeah, I normally don't do an ultrasound for that one. Plus, it's too complicated already with a lot of things going in and out, and yeah.
I think we have a follow-up question in regards to the lipid emulsion, and you can correct me if I'm wrong. Which fluid do you use?
So you can use saline. It's gonna be like normal saline you can use to dissect. Um, it's gonna be a little bit uncomfortable, but you can use it, and or you can mix it with a little bit of anesthetic. But yeah, I normally use that.
And someone wants to know your thoughts on paravertebral block for lower limbs.
I haven't walked into that. I mean, the closer you are, bigger risk there is into having a complication, and for doing that in primary care, I'm not sure if that will be the best context to do it. And yeah, that's my personal opinion on that.
We had a couple of questions on syringes come in. So the first one is syringe needles and spinal needles are less echogenetic. Can you say anything on that?
I mean, they sell these special branded nerve block needles, and a lot of people say that you cannot do it with one of those. But really, a normal needle, it's metal. It's gonna be hyperechoic. It's gonna be having a shadow. It's gonna look really good on your ultrasound. So they're more expensive, and they look nice and they have like even these small like marks that you can see when you're doing the ultrasound, like some lines. But I mean, for my contacts, I think I would just go with a normal spinal needle or syringe needle. In my context, if you have the resources, you can buy them. I mean, they're fancy and they have those marks that help you know the distance. But I think a normal needle looks exactly like a like special needle. I don't know if there's any literature that says that you know when you use a special nerve block needle, you have more you deliver better nerve blocks. I don't know.
Along with that syringe question, someone was asking what is the number for the spinal needle used most often?
Oh yeah. I use 20, 18, depending. It depends. I mean, I will go for 20 normally, but sometimes you might need 18 if they bend a lot. So when they're 20, 22, and when they have like they don't have a pointy tip and they're like non-cutting tip, sometimes it's a little bit hard to get it in. So I normally try to go with 18 sometimes, especially with you know different compositions of patients. Sometimes people that are like too musculature or have a lot of tissue will be harder to get the needle in. With people that are like elderly, you know, the skin is just so it goes in so much easy. So it depends a lot on the patient, but I will go sometimes with 18. Yeah, just because it gives you more control of the needle, especially when it's going in.
Gotcha. But that's a good point too, to like consider context and patient for
Yeah.
determining. Okay, so we had a couple more. What is the transducer frequency, gain, or TGC you prefer to visualize a nerve?
If your ultrasound has the preset of nerves, use it. If it has harmonics, use it. The image is going to look so much better. I mean, for these nerve blocks, because they're superficial structures, you want to use a high frequency transducer, you know, 12, 7, 10 megahertz. But for certain nerve blocks, and even in certain situations, you might need to use a curvilinear probe when your patient is too fluffy. It happened to me, especially with the popliteal. Like some people have a lot of adipose tissue just behind the knee, and I had to get into a curvilinear probe, but it's the same principle. You just want to be in plane, just want to be at the same level of the needle at your transducer. And I will increase the gain a little bit. Sometimes everything looks a little bit too dark, if especially if you're not completely perpendicular, your nerve block is not gonna look so bright.
All right. Next question. Do you advise using, I'm going to mispronounce this and I'm sorry, everyone, anxiolytic drugs despite local anesthesia before the procedure?
Hmm. I mean, for kids, I will consider it. Yes, definitely. Definitely, especially if they're in a lot of pain and they're moving around a lot. Yes, I will definitely consider it. Um, Without a doubt. Normally I will not use it, but for kids it can happen.
All right. Next question. Do we have other alternatives to use other than lipid emulsion to use for last? And what is the place of propofol despite its hypotensive effect?
So I think that you want to have like all your basic like red card shock card available. You want to have epinephrine, you want to have all the other drugs that you might need in case you might have last syndrome, in case you might have hypertension, you might want to have diazepam or any other anti-seizure medication because you know, it might happen that it will have some central nervous system symptoms. So yeah, have those around just in case, you know. I mean, remember they're rare, and if you practice before doing it and you look around and you use your Doppler and you're comfortable, those things are going to reduce the risk of you injecting the anesthetic directly into the vessel. And always before injecting, just basic things. Withdraw a little bit. If blood comes out, maybe you're in the vessel and you have to move from there. So yeah, that's what I will use. And yeah, have your red card, shock card ready at all time. You want to have it. In my case, we have like this red bag that is like the emergency code if you need to go out of the clinic to see a patient and you want to have it complete and want to check the catalyst when the medication will expired. Yeah.
Right. We had two more come in. Are there any consequences if one accidentally injects hyperbaric bupivacaine instead of regular one?
I don't know. I haven't looked at, I haven't read it, but I don't know if it will work the same, might changes of the composition, but I don't know. That goes out of my scope.
It looks like we have a question regarding carpal tunnel syndrome. Could you use a more distal approach for the median nerve to free the median nerve by the anesthetic by dissecting it?
I no, because you want to free it from where it's being compressed. So if you do it more up, you will not decompress it. You want to do it at the point where it will be more in pressure. So that's where you want to put the anesthetic or the steroid to free and to decrease inflammation from the medial nerve from the carpal tunnel. I mean, you can do it, but I don't think it will work as good as if you do it at the wrist, if you go more proximal.
And then we had a question about needle alignment. So can you say something about needle alignment with regard to probe position to increase visibility and distance of puncture from the probe?
Yeah, that's a good point. It's that's a really good point. It's really good sometimes to measure the distance of where your screen starts and where is the nerve block, and you can do that measurement either like from horizontally or and vertical, so you know how deep you're going, and you can know what needle you're gonna use. Sometimes you can use a normal needle for really superficial structures, and that might be enough for you, and you can save from spending one of those valuable spinal needles if that's the only ones that you have. But doing that measurement is a good point. Thank you, Getaya. Really good. Measure the distance horizontally and vertically. That's a really good tip. Yeah. And from the position, your probe has these marks all. So that will, if you look at your probe in a transverse or in a longitudinal, they have these marks. That's where you want to put your needle. That's where you want to go. And also try to keep it like as straight as possible. If you're angle it, you have just one small sound wave. If you're angling it, you're gonna miss it. Sometimes if you have missed the point of your needle, what you can do is just shake it a little bit and see where it's moving, and then try to find it. Be careful. You might rotate your probe, you might angle it. So try to keep it as straight as possible, and be sure that you can see your needle going into the probe in this direction. If you're going to be doing it in a transfer, it's going to be harder. I actually prefer to do it just be my eyesight parallel to the transducer or the needle and having the screen in front of me. Yes.
The question was, do you take snapshots of your ultrasound view for patient documentation?
Yes, I do. And this depends of your local guidance, but you might, I mean, for certain procedures and certain places, you require the patient to sign an informed consent because you're doing a procedure. So watch out what is your local guidance in the place where you work, and you have your informed consent and inform the patient of the complication that they might have. Those are basic things that you have to do. So, but you have to look your local guidance. It changed a lot on the place where you practice.
One more question came in. Can povidone iodine be used instead of gel?
Yes, yes, I do. When I was starting with doing nerve blocks, I didn't got my hands with uh um single-use sterile gel, but I wanted to practice. So I use just a lot of iodine. Just use a cover because iodine might damage your probe. So use a sterile cover, Tegaderm. You can use even a sterile glove, and you can and that will work. But yeah, I actually started doing the iodine at the beginning. So yeah, you can. It's any liquid actually. So any liquid that you're gonna use is gonna help.
Awesome. Well, I think we have one more question that I think is going to be good to kind of wrap up for everyone, kind of along those same lines when you started talking about how you started out. So there was a question of how difficult is it to do nerve blocks, and how do you advise starting the process of learning how to do that?
I mean, I think the amazing thing about POCUS is that there are a lot of resources out there. Unfortunately, not a lot of them are in other language that is not English. But you have the Highland group, they have amazing resources. They have an incredible book, they have an app. You really can learn a lot of things that are open access, but you have to practice. The most important thing is getting your hands on. And if you can find a mentor, you can find someone that can give you feedback, and you can send them your scans. That will be incredible. Or if you can attend just one, workshop of ultrasound, just to answer your questions, and then go on with nerve blocks. There are a lot of materials, and practice at your home. That's what I did. Maybe I'm gonna tell you a story, but let's say that my roomie was a tattoo artist. So it's harder to do an ultrasound when there's a lot of blood and pain and things. And she had some patients that just didn't want to feel the pain, and it was like, well, I have this ability. Do you mind if we do it? And we did nerve blocks for the tattoos that she was doing, and it worked really good, and it was great because patient. I mean, we used lidocaine, you know, and also with her. Yeah, this is a funny story, but she was a tattoo artist. She was my roomie. She has this situation, and I was like, I know this cool thing, and yeah, that's how it started. Yes. And pork belly looks amazing. It looks a lot like normal skin, and it has facial planes. So you can practice putting actually like fluid between those facial planes.
Wow, I never thought about like pork and like the consistency being so similar to like human muscular tissue. Like, it's really cool. Awesome. Well, that is going to wrap up our session today. I know we went a little over, but thank you everyone for your wonderful questions coming in. Thank you, Bruno, for your wonderful presentation. As a reminder to all attendees, a recording of this webinar will be made available on POCUS.org about 1 week after this session. You should receive a link via email to it. Thank you everyone again for attending our webinar, and we look forward to seeing y'all in the future. Thank you again, Bruno. Wonderful presentation.
Thank you. Thank you. It was a pleasure.